muted. Please remain muted during the presentation. We will have a Q&A session following the presentation, and you will be able to unmute your audio to ask any questions. We also encourage you to use the chat feature to pose questions during the presentation. In the chat, you will see a link to sign in for the session. Please take a moment to complete the sign-in. This is extremely helpful to us to measure attendance at our virtual session. I have the privilege of introducing today's speaker, Dr. Evalinn Borrayo. Did I get it? Okay, good. Dr. Borrayo is a professor in the Colorado School of Public Health and Associate Director of the Latino Research and Policy Center. She is also an Associate Director of the University of Colorado Cancer Center and the Director of its Office of Community Outreach and Engagement at the University of Colorado Anschutz Medical Campus, CU Anschutz. She is honored to hold the Cancer Cure AMC Cancer Fund Endowed Chair for Prevention and Control. Her work is driven by a deep commitment to the elimination of cancer disparities that affect underserved communities. She has expertise in the application of behavioral science to address disparities in cancer prevention, control, and survivorship among racial, ethnic minorities and other medically underserved populations. Using a community-based participatory approach, she has developed, implemented, and evaluated evidence-based and culturally relevant initiatives to improve health in disadvantaged communities. She leads numerous disparities-focused research projects and implementation programs in underserved urban and rural communities. Again, thank you so much for being here today, and I'm going to turn it over to you now. Thank you so much.
Well, thank you very much for that introduction. I really appreciate the invitation to present to the group, many of you who we work at one level or another. So I am hoping to just kind of give you an overview of Colorado and what are some of the cancer disparities are. Let me share my screen. And I'm hoping you can all see that. Just give me thumbs up.
Yes, we can see it.
Okay, great. And, I'm going to try to, let's see, minimize so that I can see some of you. But it's not responding. That's fine. Let me do the presentation mode. Why is this not going away? All right. Oh, I meant to erase that phone number there, but all right. As Katie mentioned, I'm the Associate Director of the Cancer Center, leading its community outreach and engagement. And what I hope to do today is just present cancer disparities in Colorado, but also give you an overview of the Office of Community Outreach and Engagement and how we're here to support the work that you do, particularly related to clinical trials and other research studies. Let me start with the NCI's definition of cancer disparities. So cancer health disparities are differences in incidence, prevalence, mortality, and the burden of cancer. But it's not just differences. There are differences across the board and across groups, but it's really the key word here is related to adverse health conditions that exist among specific populations and groups in the US. And those adverse health conditions refer to the social determinants of health that include things like poverty, housing, unemployment, lack of access to healthcare, uninsured, underinsured, and those populations who are, affected by adverse health conditions. And we know that it's not all just led by, those social determinants, that there are certain risk factors for specific populations. We know that ancestry-related biological or genetic differences play a role in some of this, disparities, differences that exist across groups, as well as some of the behavioral factors, such as high obesity rates, diet, physical activity or inactivity, the use of tobacco, the use of alcohol. Certain viruses are also associated with cancers, as we know, and there are differences across groups of risk to, exposure to some of these viruses. The lack of early detection, meaning, lack of access to prevention and screening behaviors, as well as lack of access to timely and aggressive treatment, also contributes to disparities in cancer mortality, for example, and as I mentioned, overall lack of access to healthcare. Oh, went the other way. All right, so let me just go over what are some of the cancer incidence mortality at the national level, some of the rates of incidence and mortality. And as this graph showed, the blue for male, red for female, as you just look at numbers, there does not seem to be very many disparities with the all races or the white population having a high incidence and mortality rate, except in comparisons to Black, but in comparison to other groups, it seems like there are no disparities. Now, we're just talking about the population at the population level. It is when you start dissecting the data and actually looking at subgroups and looking at the various aspects of socio-political life, including, housing, including location, including poverty, all of those factors. When you actually start looking at groups from that lens is when the disparities become more apparent. So in the case of Colorado, this kind of shows you what is the incidence, and the yellow or orange line shows the state. And as you can see, just from these numbers, non-Hispanic, white, and urban counties have the highest percentage of, cancer incidence. But then you also start seeing that other factors start rising to the top, such as living in a low poverty county is also drives some of the higher incidence of cancers. And as I mentioned, that may be related to late stage disease, because the cancers are individuals don't screen, and the cancers are detected at a later stage versus an earlier stage. And some of the groups here, like Hispanic, Black, American Indian, when you actually, and I'm going to show some maps, when you actually start intersecting with other things like poverty or rurality, that's when you see that those populations are actually significantly affected by cancer disparities versus race alone. It's a combination of this marginalized identities that create, the disparities, or that drive some of those disparities. And here with mortality, as we saw at the national level, when you look at rates, then the Black population in Colorado has significantly higher rates than the state, or in comparison to the non-white Hispanic population. But you see other groups like Hispanics also kind of getting closer to the state level and the white non-Hispanic population. And some of that is driven by those social determinants, such as lack of access to timely and high quality care, for example. You see the same thing here with urban counties. And the thing with urban counties is a lot of the disparities are driven by minority populations, high poverty neighborhoods. That's where you actually see that urban, it tends to be higher, also by numbers, right? Because we have more numbers there. But again, high poverty counties start exceeding then the state levels, and in comparison to some of the other groups, you really see that then mortality is higher in high poverty counties. Here is late stage disease, when cancer is found at a distant stage, again for Black populations, high poverty counties, and urban counties, the rates tend to be higher. And this is kind of what I had mentioned when you actually start looking at the intersection of the various social determinants. The map in blue, the darker blue signifies higher cancer disparities, and this is using the Colorado Department of Public Health and Environment Cancer Disparity Index. And the darker the blue, the higher the disparity. So you can see that in the southwest corner of the state, we see high levels of incidence, mortality, and late stage diagnosis. And this is of some of the main cancers like breast, lung, and colorectal cancer that drive the numbers that you see there in the darker blue. When you actually start looking at what other factors are happening, and this is the map in green, with the darker green signifying the urban counties, with the darker green and lighter green, or they signifies the rural and urban counties in Colorado, with the teal dots indicating where 25% or more of the population are Hispanic. And then the shaded areas with lines indicate where at least 15% or more of the population live in poverty. So you can see there where there's an intersection of those factors: rurality, Hispanic, and poverty, that may be driving those disparities in that particular part of the state. Now, as you can see, it's not the only area, but if we were to identify where those disparities are in Colorado, tend to be in those counties that are rural and disadvantaged by other factors, in comparison to the more urban areas or counties like, where the ski industry is, like Summit County, Eagle, Pitkin. Some of those counties have a lower rate of disparities. Oops. So the Cancer Center has prioritized what we call our catchment and what factors we're going to be targeting in the next 5 years. This is in collaboration with the Community Advisory Council that the Cancer Center has formed, and it consists of, some of the major Hispanic, some of the major ethnic minority groups such as Hispanic, Black, Native American, as well as, major healthcare systems, both rural and urban areas. We have some primary care systems represented in the Community Advisory Council, some community-based hospitals where individuals receive care, who are represented. And they have helped us for the next 5 years, if you will, kind of map what the priorities for our catchment are. And in terms of population, our rural and frontier, as we saw, that's where in some of these counties, the worst disparities in incidence, mortality, and burden exist. As well as for racial ethnic minorities, we see higher lung cancer, breast cancer, and colorectal cancer mortality in some of these populations compared to white or compared to their US counterparts. And the medically underserved, those who are poor, uninsured, or underinsured populations, who also tend to have higher disparities. Now, that doesn't mean that we're not going to focus on other populations or in Colorado at large. Is when we have opportunities to intervene for those populations, those are going to be our priorities. Same thing with cancers. While we, have cancers across the board that affect our state, our Community Advisory Council has rated lung, breast, and colorectal cancer as the cancers for us to focus, particularly because these are screenable cancers, so are cancers that we can, hopefully through some community-based interventions, health system interventions, we can affect. And then risk factors, as you might imagine, we have tobacco, where there are high smoking rates among minorities and in rural areas. It also tends to be pretty high among youth compared to adults. Other factors are HPV infection, where we have lower rates of vaccination against HPV among young adults, as well as in rural areas. And then in Colorado is also sun exposure, where we have high incidence of melanomas because of sun exposure. So those are kind of, if you will, our marching orders for the next 5 years that we are trying to incentivize not only research, but also the dissemination and implementation of evidence-based interventions in this particular populations of priority populations, cancers, and risk factors. Just to give you an example of if we were to compare Hispanics. So if we compare Hispanics at the state level compared to whites, they don't have a higher incidence or mortality. Same thing, you know, with some of the other populations. But if you get to compare them, and this, what you see the graphs in blue is comparing Hispanics in Colorado compared to Hispanics in other parts of the country or non-Hispanics. And you see there the darker blue indicates that breast, lung, and colorectal cancer, the incidence and mortality are higher compared to other Hispanics in the country. That's the lighter blue. But the opposite is almost the case for non-Hispanic whites, where you see that the rates of lung and colorectal cancer, the darker blue, are significantly lower compared to other non-Hispanic whites in the country. So there's almost, you know, if you just look at population statistics, you don't get to necessarily see the disparities until you start actually comparing to how well are Hispanics in Colorado doing compared to other Hispanics, as well as the white population compared to others in the state. And then that's when you start to see some of those disparities kind of emerge. And then what we have done is we have, again, tried to map visually where some of those disparities are. And this is for breast cancer. You might not be surprised that, you know, it is the southwest corner again, where we see a high incidence. And then the yellow dots indicates where there are cancer prevention and cancer treatment services. And you can see that, as expected, most of those providers will be in the Front Range area, with fewer, much fewer in rural and frontier counties, particularly in the southwest corner. We see fewer. Same thing with all the, you know, kind of middle of the state, in the east side of the state, you also see that there's not as many of the services or providers that these populations can access, yet there's high breast cancer in these populations. So I'm trying to move to the next. And the disparity index for lung cancer mirrors very much so the breast cancer, except, you know, you can also see that in those West Mountain communities, Mesa, Delta, and Montrose, you see also a high lung cancer rates or disparity rates. And some of that is driven by high smoking rates in these counties. As well as we know radon in Colorado, pretty much every county is very high radon levels. So it's a combination of factors, not just smoking and poverty and some of the other factors, but some of that has to do with Colorado having high radon levels. This is for colorectal cancer. Again, some of the south and eastern counties, as well as some of the western mountain counties that have higher poverty and more rural, also tend to have higher disparity, colorectal cancer disparity index. And here are some behavioral factors that are also driving some of those differences. We know that current smokers is higher among Hispanics. We also know that it's higher among African American, significantly higher than in other populations. Same thing with obesity and physical inactivity. And then we don't see necessarily those differences in smoking, heavy drinking, and obesity and physical activity at the rural and frontier compared to urban. But again, as I show with those maps, it just depends on where you look. If you just look at statewide, those disparities may not be as apparent as when you actually start looking at the various counties in Colorado, that those disparities become more apparent. And here with screening, early detection, you also see some differences among Hispanic having lower, colorectal cancer screening rates, mammography rates, but same thing for rural and frontier, they tend to have lower, significantly lower than, compared to non-Hispanic, white, or urban. And what this map shows you here is, kind of at the state level, where our patients come. They really come from every county, with the majority of them coming actually from the Front Range, which is what we expect. Most of the UC Health sites are in the Front Range, but you can really see that we have patients coming from all over the state, which is our catchment. The majority being urban, with about 8.6% being rural and about 10.9% being out of state. Fewer tend to be Hispanic. 7.9% of our patients are Hispanic, and that does not compare to the state population that comes, I believe, is 22% of Hispanics in Colorado. So we definitely are not capturing that population as well as we could. And the majority are non-Hispanic with a few unknown ethnicity. So I would like to, before I move on to the next, actually allow for questions. I'm going to be talking about the Office of Community Outreach and Engagement and, what we do and who we are, but just wondering if there are any questions. Katie, if that's okay to ask questions now.
Yes, you bet.
Okay, I don't see any in the chat. And all right, well, let's keep moving on the presentation. So what I would like to do is just kind of tell you more about the Office of Community Outreach and Engagement. We officially got started in 2019, and we have a small team of 6 individuals at the time. And myself, so 7, where our charge is to really lead for the Cancer Center a greater outreach to communities in our catchment, which is the state of Colorado, but also the dissemination of evidence-based interventions, the inclusion of underserved populations in clinical trials and research studies. So I'll be just kind of giving you an overview of our office, and for some of you who are interested in increasing representation in trials or representation in your research studies, please don't hesitate to reach out. And some of you might have seen this presentation because we presented to the disease-based teams. But so our Office of COE has 3 aims. One is to monitor and disseminate with up-to-date data what the cancer burden, risk, and disparities are in Colorado. And some of the maps that I show you and some of the graphs that I show you is doing exactly that, really trying to assess where those disparities are. This map here is another example in which we have identified, in the darker blue are all the counties that are rural that have disparities or a high disparity index compared to the rural non-disparity are the darker orange. And as you see, some of that includes some of those counties in, the ski resorts and the less, disparity in terms of race, ethnicity, and socioeconomic status. With the lighter blue indicating those counties that are urban, but also have disparities. And the lighter orange is the counties that are urban and non-disparity counties. Now, again, this is just considering at the population level versus actually start looking at the subgroups such as minorities, such as poverty, communities. Those are not necessarily, driving, or they don't seem to be driving the disparities in those counties, but they are affected by cancer disparities. Our second aim is to facilitate for our cancer center members to engage in more community-led research that is relevant to Colorado and beyond. The other one is to engage communities in the implementation and dissemination of interventions across the cancer continuum, from cancer prevention, control, survivorship, and treatment. Some of the partnerships that we have is providing clinical trial education, and I'll be going through some of this, as well as translation. We're about to put together on the Community Advisory Council. We're navigating patients. We're also providing information and doing community outreach and engagement, as well as participating with the coalition in statewide task force to engage more populations of color and other underrepresented groups in clinical trials. So let me tell you a little bit about the clinical trials education that Chris Jones leads for the office. This is basically a 20-30 minute one-time virtual education session. We can do it in groups, or we can also do it one-on-one. We're evaluating. We have some funding from the NCI to evaluate whether this approach of educating communities about clinical trials, how effective it is, how it increases people's understanding of clinical trials. So it covers some general information about what clinical trials are, what some myths might be out there of clinical trials, as well as giving people information of how they can enroll in clinical trials, giving them some websites. And again, individuals who attend receive a small incentive to answer a pre and post questionnaire, and we have them available both in English and Spanish. We recently started a great collaboration with Supportive Oncology, and our presentations and clinical trials have significantly increased. We're also collaborating with schools and other community-based organizations that are interested in us presenting more about clinical trials. The other one is we also have English-Spanish translation. Now, this is in an attempt to improve the representation of Hispanic and Latino patients in our clinical trials, because it's below the state cancer rates in terms of the number that we get to engage. We are focusing on the translation of, strategies to be able to engage Hispanic and Latino patients, and also assisting with what kind of strategies investigators and their teams can apply and collaborate with us in terms of how to reach to that population. We're also doing translation of IRB approved protocols, informed consents. It's free of charge. Now, we're not a shared resource. We are more of a tool, if you will, where our cancer center members can say, look, I'm really interested in improving the representation of Spanish-speaking Hispanic populations. How can we collaborate? How can we work on this? We're also focusing mostly on investigator-initiated trials, meaning we're not really focusing on industry, because those industry-sponsored trials tend to have more resources for translation. They also have certain protocols in terms of how the translation needs to be done. So we're focusing mostly on investigator-initiated trials, working with OCRAS, working with CCTO in how to improve, this resources for our investigators to improve representation. We also try to follow up with investigators 6 months later, just to ask, so how well is it going? Have you been able to engage more Hispanic or Spanish-speaking patients? What may not be going well? How can we help? So it's not just only English-Spanish translation, but also engagement of those populations. And that is led by Ale Soto, who is our Cultural and Linguistic Competency Coordinator. Ale is also leading a patient advisory panel. We recently were able to hire Dr. Jan Lowry, who is one of our assistant directors for dissemination and implementation. And she has quite a bit of experience in putting together this patient advisory panels. But the idea here is to put a group of individuals who are interested, potentially patients that have received care here, their caregivers, or just patients in general who are interested in improving representation in research and providing feedback. And the idea will be to train them, provide some basic understanding of what research is, what protocols are, and helping the teams in reviewing grants, the protocols, or some study-related documents. So this can be, their involvement can be before a grant gets submitted or after a grant gets submitted, how to improve, some of those protocol documents and procedures to improve representation. Participation, hopefully they can also participate in some of the meetings with the PI or the research teams. This will be left up to the teams of how much involvement they want. We know that there's certain funders like the Department of Defense who require investigators to have the voice of patients. PCORI, the Patient Reported Outcomes Research Institute, also requires involvement of patients. So those may be more involved than perhaps some NIH or other funded projects. We, the Office of Community Outreach and Engagement, will be providing an incentive on an hourly basis for our patients to help research teams. And, we need your help to enlist some of these patients so that we can have a broader representation of our catchment. So not just your typical patient, but more from rural areas, from minority groups, from patients who may not have had access, but got access to our care. So we really need help with putting together, and hopefully this fall, we're going to be putting this group together. So we welcome recommendations, if you have them, of patients to include in our patient advisory panel. We also provide Spanish-speaking patient navigation, and this is really across the board, is not just for clinical trials, but how to engage overall more Spanish-speaking patients. We have one project, or we have several projects actually, with Denver Health, who is the safety net hospital for the city and county of Denver, where they have a high percentage of Spanish-speaking patients. We have an HPV project, for example, with Denver Health, navigating them to the vaccine, educating them about HPV and HPV relationship to cancer. That's with Denver Health. We also have another project that Dr. Jessica McDermott leads. Is what we call E3, means Esperanza en Español, with the 3 E's. And this is in collaboration with Denver Health, trying to navigate some of their patients to our clinical trials. And Carlo has done a wonderful job really working with these patients who otherwise would not have access, getting them through the door of UC Health, working with UC Health, and eventually navigating them to clinical trials. We're also connecting patients to the appropriate specific clinical trials team. So we navigate them up to the door, and then, the CCTO team takes over with these patients if they qualify for clinical trials. Most of our navigation is focusing on the social determinants of health, things as how to help patients either find insurance or supplement their insurance, how to find resources such as transportation. Some of them may need vouchers and other resources that make a difference for them to be able to access clinical trials. Connecting them with resources both at UC Health, the university, or the community. And assistance with filling even some of the forms, the financial assistance, whatever it is that the patient needs that is within the scope of what we do, we really try to help them so that they can access clinical trials. And Carlo leads that effort. Carlo also leads an effort of identifying at the state level what are some of the resources. And this particular website lives at the Cancer Center within the Office of COE. And we have identified, for example, where individuals can get low or no cost cancer screenings, where they can get genetic counseling and testing, where there may be providers, of radiation, chemotherapy, surgery. If you click on those links, it will take you where on the state. And as I show in the map, most of them are focused in the Denver metro area, but also in some of the rural communities, palliative care, and some additional resources such as insurance, or maybe there's some community specific programs that can help individuals. Those can also be found there. We also do a lot of community outreach and engagement, as our name implies, attending community events across the state, some policy events at the Capitol, as well as health fairs. We just started a wonderful collaboration with 9 health fairs, which I think is now they're called 365 health fairs, distributing fit tests for the detection of potential screening for colorectal cancer, and then navigating patients to colonoscopy, attending conferences at the state level, collaborating with the coalition, disseminating information, all kinds of information, particularly, related to some of the risk factors. And, in general, collaborating where our community partners say they need assistance from the Cancer Center. That enters into our umbrella of community outreach and engagement. At the statewide, Daniel Pacheco, who is our program manager, in collaboration with, several of us, we're leading the CU task force. We meet monthly to identify barriers and what are the patients experiencing in accessing care. We're working with partners such as Denver Health to provide patients access to clinical trials. Daniel and Dr. Jessica McDermott lead the Colorado Cancer Coalition Clinical Trials Task Force. This is a newly formed task force trying to align, some of the efforts happening statewide with the Colorado Cancer Plan that includes increasing access to clinical trials, trying to gain representation from across the state of providers, community-based providers, clinics, hospitals, and trying to identify some barriers specific to some of these populations who are in rural areas, or who are ethnic minorities, who are low income, uninsured, underinsured. What are those barriers to clinical trial representation? So that's basically what our office does. Let me stop sharing and see if there are any questions. Happy to answer any questions. Or it was so thorough that nobody has questions. That would be fine too. Feel free to put it on the chat, or Dr. Jamie Stutz.
Evalinn, could you say a little bit more about how you have worked to integrate the community perspectives into the selection of your of the topics that need to be most focused and front and center for Colorado?
Thanks for the question. Yes, the charge for the Cancer Center is to include community voices across the board, but particularly about include stakeholders who are already working addressing health disparities in general, but particularly cancer disparities. And so we have representation from some of the major healthcare systems, both primary as well as cancer treatment hospitals in the state. We also have representation from communities of color and other underrepresented populations, such as the LGBTQ plus populations. And the idea, and some players like the Colorado Cancer Coalition, the Colorado Department of Public Health and Environment, We also have the Lieutenant Governor's office, and the idea is to bring all the stakeholders and listen to what the priorities are in the communities. A lot of the maps and statistics that I show you are data, but they don't necessarily represent what the community's priorities and needs are. So this is where we solicit some input through our Community Advisory Council. We also work closely with some communities through regular meetings and other venues, working with the Colorado Cancer Coalition, participating in their task forces, and really trying to listen to what the community is saying are the needs and how best to address some of these disparities that we have identified. Hopefully that answers your question. Other questions?
I have a question.
Sure, Rachel, please.
I was wondering if you could go back to the slide, and I could be misspeaking right now, but where you talk about someone leading an effort to bring in, excuse me, non-English speaking patients to like sit in on research meetings or review documents.
Our patient advisory panel.
Yes. So those patients, are they like reviewing consent forms to look at like the translation? Does the translation make sense from English to Spanish, or can you talk about that a little more?
Yes, absolutely. So we haven't formed the advisory panel yet, but that is in the works. We're hoping that this fall is one of the things that we'll be able to, put together. And the charge is going to be how to assist investigators in including more diverse populations, underserved populations. And that could include translation of protocols or translation of informed consents. Ale Soto leads that, the translation for our office. The advisory council may be more engaged in providing feedback on, how attractive some materials might be, what may be some community, factors to consider. So it's more from the patient perspective, the community perspective that they're going to be advising. They could also look at translation, but we have Ale, who is our cultural and linguistic competency coordinator, who helps with investigators in translation of protocols or protocol materials, I should say.
So that helps. Thank you.
Absolutely. And we do some of these presentations with the disease-based teams, and we hope to continue to do these presentations just to make investigators and their teams aware of what kind of resources our office has to help them improve representation. Happy to contemplate other questions if there are any.
Evalinn, you guys have done a great job of adding Spanish language translation. Do you foresee a future for additional translation options, a need for addressing heterogeneity in language more broadly than Hispanic, Spanish and English?
Yeah, I think that would be wonderful if the Cancer Center gave us more resources. We'll be happy to add to our team of translators. Some of it depends. Our population of Hispanics is small, and it's even smaller of other non-English speaking populations. The translation for cancer treatment really falls more on the UC Health side, and for us is more investigators. But currently we do not have other languages, translation for other languages. Other questions? Well, I don't see or hear any other questions. So I really appreciate the opportunity to be able to present, and please don't hesitate to reach out. If you just look up Office of Community Outreach and Engagement, you will find a lot of our contact information. Dr. Jan Lowry, who have just joined, she's our new leadership addition, leading the dissemination and implementation of evidence-based interventions in the community, as well as following our metrics and doing some of she's trained as an epidemiologist, so she's also going to be leading our catchment analysis of where those disparities might be at the state and county level, as well as subgroup subpopulations. All right, well, thank you very much for your time. Really appreciate you being with us. Katie, I don't know if you have anything else.
I don't. Thank you so much. This was great. We really appreciate your presentation and the overview. Such great information. So thank you. All right.
Certainly. Thank you, everybody. Have a good afternoon. Bye.